when we decided to look at lenalidomide, we first decided we should see if we can emulate a transdermal patch with a subcutaneous infusion. Most animal studies for tumors are done in severely compromised immune deficiency mice. And we first decided we needed to assess the safety of drug given by continuous infusion in a healthy mouse. Those were given at a dose of 25 micrograms an hour, 12 micrograms an hour, 6 micrograms an hour, and 2 micrograms an hour. What we found was if we exceeded the 6 microgram an hour in healthy mice, we saw toxicity in the animals. So we were able to identify from the first healthy volunteer study of mice the safe dose for targeting in the tumor study. On the left side of that image is a small pump that's actually implanted into the mouse. The reservoir is filled and it will continuously pump drug for 14 days. In the study, the tumor xenograft study, we replaced that pump twice. Those animals were grafted with a H929 xenograft tumor, which is a multiple myeloma tumor model. That tumor was allowed to grow in those mice until it reached a certain size, and then the mice were enrolled in the study. We had a group of animals who had no treatment. We had a group of animals who received lenalidomide, 25 milligrams per kilogram once a day by intraperitoneal injection. We had 4 mice at 6 micrograms an hour infusion rate, 2 microgram an hour infusion rate, 1 microgram an hour infusion rate, and a half a microgram per hour infusion rate. Those went for 14 days. The pump was replaced and animals then were treated for another 14 days for a total of 28 days on study. The efficacy results were highly unexpected. And by that, if you think of we're giving less drug, we have less exposure, but we saw better results. And what are those better results? In animals treated with the standard of care lenalidomide, which is the blue arrow, blue line, animals had a median time to progression of 47 days, and all had progressed by 52 days. At 6 micrograms per hour, the green line, you'll see that the mean time to progression was 65 days. This is a doubling of survival. And at the end of the study, 2 animals still continued to be tumor-free, and we had to sacrifice those animals. Safety was also required, and these are just some body weights. I won't spend much time here, but what we saw is that there were no significant toxicities as defined by a reduction in body weight with the continuous administration of lenalidomide. Hematologic malignancies are the primary dose limiting events associated with lenalidomide, and it affects the ANC or the neutrophils and the PLT or the platelets. And group 2 is the animals that receive lenalidomide by once a day injection. Group 3, 4, 5, and 6 are the animals that receive continuous infusion. And you can see from the blue, which is early in treatment at day 8, and in the green bar at day 22 shows that there were no real differences in the response of the neutrophils or platelets. In other words, we didn't see toxicity from those elements associated with the subcutaneous administration of lenalidomide. Pharmacokinetics are a critical factor in the delivery of drugs that are used by this method because we select a target concentration that we want to achieve. This slide shows you that at the 4 doses of drug that were given by subcutaneous continuous infusion, we had very consistent blood levels. Those blood levels were what we projected them to be, which is important to realize. And you'll see that we were treating at about 23% of the dose by the traditional standard of care method. So 25 to 30% of the total exposure at a more efficacious outcome. These data, again, are pretty remarkable in that normally we don't expect to see reductions in dose associated with improvements of outcome. So the summaries are that we had very much anticipated results with continuous lenalidomide. There have been no published reports of parenteral administration of lenalidomide. In fact, we have to manufacture our own parenteral solution. Continuous administration of lenalidomide was well tolerated at targeted doses. We were able to flatten the curve successfully and reach our predicted blood levels when we gave subcutaneous lenalidomide. The total exposure, as I mentioned before, were greater than 70% lower than the standard of care dose. Despite the reduction in dose, these group 3 animals, the ones who were treated at 6 micrograms an hour, were superior in their outcome to standard of care lenalidomide. And we believe these data support the continuous use of lenalidomide in CLL and multiple myeloma. And then the last slide, again, just takes you back now that you've heard a little bit about how drugs are delivered and why we seek that certain blood level. In this case, this will be our first dose that Dr. Chanan-Khan will talk about in our newly designed CLL study. At 100 micrograms an hour, we'll achieve blood levels that are in the red zone and well below the peaks and troughs above the troughs of the standard pulsatile dose. We can either take questions now, or I think we're going to have them at the end of the meeting, if I'm not mistaken. If there's anything you need to know, just let me know. Thank you. Dr. Chanan-Khan, you want to pick up, or are you able to?
Yes, I am. I think I'm unmuted now, and should stop. Okay, this should do it. Thank you so much, Amy. Thank you, Pedro, for nice introduction. And Sydney, thank you for arranging this. I appreciate all of you who are listening. I am Chanan-Khan, Professor of Medicine at Mayo Clinic, and have spent the last 25 years in hematologic malignancies, specifically focusing on B-cell cancers, CLL, myeloma, Waldenstrom. Lenalidomide has been a very close ally over the years in taking care of patients. I was instrumental in development of lenalidomide from the very beginning. I was the first one to report its activity in CLL, where that's in 2005, 4, 5, and have used other IMiDs as well in CLL, and has a vast experience, multiple publications demonstrating its efficacy. So in the first part of the talk, we'll look at chronic lymphocytic leukemia from my eyes. The second part is the landscape. A lot of you may already be aware of it. And the last part is why we think CLL and lenalidomide are a good fit for development of our first strategic approach to get this thing approved. Sydney, do I have control, or do you have control? Could you move the slide?
You actually have control, Asher.
Okay, let's see. Okay. So chronic lymphocytic leukemia is one of the most common leukemias in the Western Hemisphere. Between the US and Europe, this is one of the most common leukemias. And there has been a lot of activity over the last 7 years or so, and it's been very encouraging. But for the longest, we didn't have much. When I started in the field, there was only 1 or 2 regimens. Rituxan was there, purine analogs were there. So there's about over 150,000 to 200 cases a year. In terms of hematologic malignancy, it does have the lion's share. about 16,000 cases are diagnosed each year. These patients live long. And so they require frequent treatments over a long period of time. Their median time to diagnosis is in their 60s and 70s. I see a lot of young patients now in their 40s and even late 30s started to see them. Typically, the approach had been to do nothing to them until they become symptomatic. So we started from a place of basically failure. We just wanted to treat when symptoms were really bad, and because we didn't have many therapies. It's an open field for development of immunotherapies and so forth, because early intervention was tried many years ago, failed because we tried chemotherapy for that, and subsequently gave up. Typically, the median survival of patients are over 10 years if they're low risk. If they're high risk, it is as low as 3 years, and it's really bad. And then there's an intermediate risk category, which ranges from 5 to 7. A lot of genomic studies have been done to ascertain how we can risk stratify these patients, and that allows us to look at how to triage different treatment for them. Clinical presentation typically is lymphocytosis. White cells are high, lymph nodes are large, spleen or liver can be enlarged. Patients typically have bone marrow involvement, and that results in anemia and so forth. And there's immune dysfunction, and the immune dysfunction results in infections, which actually is one of the most common cause of death in these patients. Diagnostically, it's very easy. The tumor or the cancer cells are in the blood, and we can do a simple flow cytometry with this panel, and we can diagnose patients with CLL almost in the same day. There are several prognostic markers, and you'll see in various studies these reported. The most critical that I rely on are CD38 and the cytogenetics of a patient, such as chromosome 17 and 11q deletion. And one other is the heavy chain gene mutation. So IGVH is something that, in my mind, dissects the CLL in 2 categories. If they're unmutated, they're aggressive. If they're mutated, they're less aggressive. And then you add the cytogenetics, and then you add the doubling time and all of the and CD38 expression, and tease it further. There are multiple factors in the microenvironment. We won't go into detail, but these are all relevant in the biology of the CLL. IL-10, TNF-alpha, VEGF, and they play certain roles, IL-6, and some are related to lens activity and lens ability to modulate some of these cytokines, others are not. But these cytokines are very, very important. What is very interesting about this disease is the fact that it is a white cell. It comes from a white cell, it comes from the immune system. And therefore, it has developed mechanism of evasion. So it sits right in front of the immune system, and the immune system is unable to detect it because it's able to downregulate certain markers. Think of it as a pirate ship sitting right in the center of it with the pirate flag down. Nobody can identify it. And these are markers such as CD80, 83, 86. Now, in this slide, this is the only point I would like you to remember, because when I talk about lenalidomide, you will see that our work has shown that one of the activities of lenalidomide is to upregulate or force the pirate ship to expose its colors. And so that is a very powerful tool. And then there are certain pathways in the CLL that are important. I find BCL2 very important. I find the BCR signaling, which is B cell receptor signaling, where BTK falls into place and PI3K falls into place, are very important. If there are 2 pathways that you want to remember that are validated both clinically, biologically, and therapeutically, these are BCL2 and the BCR itself. Now, if you look at the IGVH mutation, and these are graphs that I mentioned earlier on showing the mutated over here at the bottom, seems to be mutated on the top and unmutated at the bottom, display for you what I just mentioned earlier on in terms of aggressiveness of the disease. And similar is the case with cytogenetics. And these are documented, well-documented data set. Why is it relevant? Because lenalidomide has shown that it overcomes all these high-risk features and are able to deliver responses even when you have IGBH unmutated, even when you have cytogenetic aggressive disease, such as 17p deleted or 11q. We have demonstrated, we've reported that, and it's already in medical literature. And so this graph basically highlights is to show you that people who are deletion 17p or 11q tend to have a really aggressive clinical course. And it's typically what people think, oh, the CLL is a nice disease if you can live forever. Not for everybody. There are people who are dying in less than 3 years and so forth. Now, BTK inhibitors have changed that a lot similarly, and you can see the advantage that lenalidomide will have by overcoming these high-risk features, as BTK inhibitors or ibrutinib and acalabrutinib have demonstrated advantage to those drugs by overcoming these features. Now, typically, the clinical course can be variable. If you let a CLL patient live long enough, 70 to 80% of them eventually will require treatment. So a large patient population will need therapy at some point in their time. They may start slow. You may not need any treatment or if they don't have symptoms, but eventually they will reach a point that treatment is required. And typically those clinical parameters as anemias and fatigues and large diseases and big bulky lymph nodes or recurrent infections and so forth. And all of these I see when I decide to initiate treatment in these patients. And these are indications that we typically use to enroll patients in clinical trial, to bring them into remission and then maintain them in remission. Typical strategy, we will talk that defined period of treatment and then nothing versus continuous treatment. The NCCN guidelines allow us to look at two different staging systems, the RISE staging system from Dr. Ryan, Long Island Jewish, and Binet system from Europe. And those are the high risk people are typically the 1, 3, or 4 stage RI or C are those which have bone marrow failure, anemia, thrombocytopenia, or low platelets less than 100. These are the people that definitely need treatment because their disease is taking a toll on them. And to bring Jamie's comment regarding toxicity of lenalidomide in context with this, it is important to know that if you already have cytopenias, then having a higher dose of lenalidomide becomes more challenging to deliver. And so this system of delivery allows us to have the same benefit, or at least that's what we anticipate, allow us to have same benefit in terms of therapeutic efficacy with minimizing the toxicity aspect of it. So disease parameters, disease biology does help us select this disease for len development. These are just indications, again, to see when a clinician is prompted to treat. And again, high disease burden, impact on the body, such as failures of bone marrow to function or infections or failure of the immune system and so forth and things like that. Diving a little bit more deeper into the pathways that are relevant. And they're very relevant because there are therapies that are pathway specific. So the biological pathway that are of key importance for you to remember are the BTK or Bruton tyrosine kinase or PI3K, or the BCL2 pathway and the CD20. They all at some point interlace with each other. So my lab has worked a lot in terms of CLL cells, uncovering which pathway at which time point is more relevant and should we go after that or not. What distinguishes lenalidomide from these is that it is pathway agnostic. So when we have exhausted potentially all targeted therapies, one can contemplate that BTK failed, a PI3K or a BCL2 failed, one can contemplate that a pathway agnostic or pathway independent drug such as lenalidomide may overpower the cell again because it's not necessarily relying on CD20 or BTK and so forth. So for BTKs or B cell receptor pathway, this is the pathway that is highlighted, very well talked about. At least 3 drugs are already in the clinic and at least 3 to 4 more being developed. The bottom line is, like, you can have 10 BTK inhibitors. They all bind to BTK. So when you fail one BTK inhibitor, basically the pathway becomes redundant. You may get some mileage with drug 2, drug 3, drug 4, and that may be just the binding potential, higher affinity, and better tolerability, being on schedule because of tolerability. But at the end of the day, biologically, if the cell decides to become resistant to a pathway, then that whole class does not work. And so it doesn't make sense to have 10 drugs in one particular pathway, albeit if you were to pick and choose for toxicity purposes. So when I am in the clinic and somebody asks me, should I use acalabrutinib, ibrutinib, or zanubrutinib? My typical is, hey, let's look at what other problems you have and try to pick which best fits your needs. Is it the schedule that's important, twice a day versus once a day? Is it concurrent ailments that you have that prompts one versus the other, such as atrial fibrillation and heart complications that other BTK inhibitors are? So what the point here to highlight is that, yes, there are multiple BTK inhibitors being developed for CLL, but they are all acting at the same spot. And so there is room, very much so, for patients to benefit from additional development of drugs that are independent of that. Now, this is the RESONATE study in relapse CLL patient that was reported in the New England Journal a while ago. Ibrutinib was compared to ofatumumab, so a BTK inhibitor, compared to a CD20 inhibitor. And so you can see the results very clearly that ibrutinib, when you went after a specific target and that the cell was very reliant upon, you were able to show significant benefit in progression-free survival and in significant benefit in overall survival. Now the curves are very close in the overall survival and so forth, but clearly it was significant enough to make a difference in terms of approval and so forth. So this is a study that I had the good fortune of leading internationally, one of the largest at the time studies, over 700 or so, or 500 or so patients at the time that we enrolled. This is the first time that a BTK inhibitor was combined with chemotherapy, and to show that whether a targeted and a chemoimmunotherapy approach would be better or not. And so you can see here the progression-free survival is significantly better because the targeted therapy enhanced the effect of the chemoimmunotherapy approach. And again, these things are over and over visited with different clinical trials showing that when you have targeted therapies and engaged in a specific manner, whether be chemotherapy or other targeted therapy, there will be an enhanced effect. The ASCEND trial is an acalabrutinib, which is the second BTK drug that is now available, compared to either a PI3K and Rituxan or a chemorituxan. So the novelty of this study was that a targeted therapy as a single agent was punted against a targeted therapy for a different target with an immunotherapy or chemo plus an immunotherapy. So very interesting, innovative design to prove a point. And what we ended up finding with the ASCEND trial, that if you have acalabrutinib or just a targeted therapy, you pretty much blew the cell out of water for some time, and progression-free survival was significantly better. Now, why would that happen? And one, it's a very tolerable drug. very effective. Delivery is very nice, versus chemotherapy where you have other issues and complications and so forth. Now, IDELA, our PI3K, has been a tough target for CLL patients. The market share for that is in 2 or 3%, if I'm being generous. And I've talked to people in the field where they are in the process of marketing and figuring out ways how to promote use of idelalisib. It's a tough drug to give. So now when we start looking at the pathways, you say, well, BTK drug development has been really good and very tolerable. And the second pathway that is very relevant does work. There are no drugs that a clinician is willing to prescribe or willing to advocate for, short of really, really, really desperate situations. And I'll tell you, in my practice, it's been a handful of cases that I write that in very desperate situation. And the third pathway, which has been really exciting, and I have spent over most of my career in researching, is the BCL2 pathway. So any and every drug that you can think about that has anything to do with BCL2, I've had the opportunity to work with it, if not clinically, definitely in the laboratory. And in this particular clinical trial looks at venetoclax and rituximab versus, again, chemotherapy and immunotherapy, rituximab, to show whether there's any benefit or not. And again, BCL2 is a very, very solid player in CLL. And if you go after it, you will see benefit. And it took us a long time, us meaning the medical community, to find the right BCL2 molecule to be able to show that a disruption of BCL2 pathway will deliver similarly as disruption of the BCR pathway through BTK will deliver responses. So this particular study also showed on the on the left-hand graph, you will see the progression-free survival benefit. When this study was released in a journal, the survival benefit was not there, but you can see the overall response rate is 90%. When I started in this field, the chemoimmunotherapy would deliver a response around best 50 to 60%, and that's exactly what it is in the control arm, 67% at best, and that's with bendamustine. But with the targeted therapies, you are able to achieve very high level of remission rates. The challenge with targeted therapy has always been, and with chemotherapy, that eventually the cell does become resistant to that. And it does have these, because it has multiple pathways, as I mentioned, it does propose itself an opportunity to shift or repivot itself from one pathway to the other. And therefore, a pathway, a therapy that can come above these pathways will be really, really beneficial for CLL patients. So this kind of slide summarizes what we have. We have CD52, which is like an old drug, alemtuzumab or Campath. If you guys have not heard of it, it's because it's so toxic, and I've used a lot of it when there was nothing else. And as soon as there's alternate options came, this drug actually went out completely. It works. Every time I've given this drug, it works. So the lesson learned is that, yes, sometimes the drugs are so effective and they do work, but the toxicity profile is so unpleasant that the clinicians just rather not do that. And they defer those treatments to the later part of the treatment paradigm. And if we can improve upon the toxicity and tolerability of an active molecule just by changing the PKs and so forth in delivery system, voila, we have another opportunity for a new drug, and that's alluding to lenalidomide. And all the CD20s and BCRs are listed over here as we talk. On the right-hand side, you will see the lenalidomide, which doesn't specifically target anything inside that is known to cause or drive the CLL cells proliferation and resistance. And so that's what I have been consistently mentioning. The lenalidomide's ability to bring the immune system into play against the CLL cell is its unique and its exclusive property that makes it very attractive to deliver. If you look at the NCCN guidelines, actually, it is already acknowledged that lenalidomide, either alone or in combination with rituximab, is a bona fide option for relapsed CLL patients. That shows you that even the expert panel across the country, when we sit down and have the good fortune of being part of this group who writes these recommendations for the world. So for the last 20 years, I think I've been with them. And I've seen this chart evolve so much that lenalidomide, being able to make it is very, very important. So we are coming from a very strong position in drug development for Starton, because we have a drug that is already working, is already endorsed by the experts in the country as potential therapy for CLL patients. But how do we use it that is much more safer, convenient, better for patients so that its utility is enhanced? So the data that supports the NCCN's position and the position of Starton in going first in CLL comes from some of these papers. There are several. The first one that you'll see is a phase 2 trial that I had was blessed to lead and think and design. At that time, in 2003, nobody was thinking about IMiDs as a potential mechanism or drug to target CLL. And the rationale at that time came from the cytokine milieu that I showed you earlier on. Immune effects were not necessarily teased out at the time. I was going more the VEGF route, which was what IMiDs were talked around a lot. A lot of literature was on that. And subsequently, we saw that in this first study, about 55 or 60% of the patients went into remission, even with high risk. What was also interesting, even in that first study, was that molecular remission, PCR negative CRs were noted. And that was phenomenal. The third thing that I realized at that time was the immune activation, that the immune system was rigorously activated by lenalidomide, and to almost to its detriment. This was not anticipated because lenalidomide, when given to myeloma patients, don't activate immune system as robustly. It does at a very subclinical level, but not at a clinically evident level that could be really good. So I'll show you some of that. But what it led to over my investigative period thereafter was this particular diagram that was published, I think, in Lancet a while ago. So then the heart of the cell is the CLL cell, and then it interacts with the stromal cells through various cytokines, VEGF, SDF1, CXCR4, and things like that. And I had asked you to remember the CD80 at the bottom, 86. These are markers of recognition for immune markers that T cells can recognize. What we learned that when len is given to CLL cells, either in vitro or in patients, it forces them to upregulate these markers, CD80, 86, 40. That then allows the immune cells to immediately wake up and says, whoa, this cell has been sitting right in front of me and we need to go after it. So first, it exposes the malignant nature of the CLL cells to the immune cells. Second, lenalidomide directly acts on the T cells and the NK cells. Both NK cells and T cells get charged up. They are charged to attack. And so they start to proliferate and they go right after that. And that results in a very potent immune reaction. And this is some of the data that we show you. On the right, on left side is a graph that of a clinical trial that I did with thalidomide, which was a precursor to lenalidomide. In 2000, I started my first trial with IMiDs, which was thalidomide. And you can see most of the patients have a significant decline in their leukemic burden in the blood. And then I started the lenalidomide trial, which shows on the B figure, showing that most of the patients that went on showed a decline in leukemic counts right after starting. And this is 7-day data. Within 7 days, this is results we're seeing. It's not 7 months. 7 days, you see a response in that. And the ones that flared, you'll see these two red, they jumped up and scared me. And initially I thought, oh, wow, what's happening? Are we activating the immune system? But there are patients which are called flare reaction. In fact, we were the first one to show what a flare reaction is. Now you see flare reaction with even ibrutinib that lasts for 6 months. But that phenomenon was not known until I had treated these patients with lenalidomide. So this is a patient on the left-hand side where there's a huge mass that is red and inflamed. She was my patient. She had CLL. She had golf-size lymph nodes in the neck. I gave her lenalidomide. A week later, I see her. Her neck is red and inflamed and like a softball, and almost to a level. Fortunately, we were diligent enough to convince her, because of the redness and so forth, that I need to take a piece of this. And so we took a piece of this inflamed mass, and we found that the tumor, the lymph nodes of the CLL were completely infiltrated with immune cells. And that was the first clue that we got that actually lenalidomide is doing something locally to the CLL cell as well as to the immune cell, bringing them together and causing this. Now, this patient went in, she was from Cleveland. This patient went into complete remission. This whole thing was dismissed. If you look at the paper, you'll see the follow-up picture of that, and absolutely gone. But it took her about a month to get there. This is a 7-day picture. And you can see the flare reaction listed here. What was also important is the fourth figure, or the second, on the second row, first figure, which is this probability of CR. We were able to calculate the probability of CR. The higher the grade of flare, meaning the more you activated the immune system, the better the probability that a patient would go into complete remission. And on the right-hand side is data showing that that correlates with the CD molecules that I had asked to remember, CD 83, 86, 80. These markers, when they get upregulated, do call upon the immune cells to come and act. And so, and as a result, the immune response happens. All of this data then resulted in 2 very important large clinical trials that I partnered with Celgene and had the opportunity to lead these studies. The Continuum trial was a phase 3 trial of maintenance lenalidomide. Why is this important in today's discussion? Is because maintenance is something that we are looking into as a development path. And this drug does work very well in maintenance. It's niches in continuous therapy of continuously activating the immune system. And so the primary endpoint of this, of course, were progression-free survival and so forth. And it was about 680 patients that we had enrolled internationally. And there was a progression-free survival benefit and noted with a significant p-value. The overall survival benefit was not translated into as significantly as the initial report, but subsequently P was 0.00007. This is the second time that they did. And the reason probably was from the toxicity that some of the patients incurred as a result of not being able to manage the flare reaction or not be prepared for that and so forth. The next trial that was of key importance were in the elderly, which was lenalidomide compared directly to chlorambucil. And at that time, chlorambucil was the standard of care to compare, as has been with many other drugs that have done that. And in this particular trial also, you see that len significantly had the probability of overall survival was in favor of lenalidomide, even in these elderly patients. Now, the elderly patient is a tricky group from a biologist and from a clinician's perspective because len is renally excreted. And so if nobody's checking renal function or creatinine clearance, then they may overdose the drug. And that happened in many instances across the globe where people were not very savvy that the myeloma dose may not be the right dose for CLL patients because it's much more immune active, and we really need to keep an eye on how the dose is. And that's where Starton technology does help, because we are staying so low. Our goal is to stay so low that it becomes independent of renal function and so forth. So to summarize why CLL is important from a Starton perspective in context with development of lenalidomide. One, it's a very common disease, so there's lots of patients. Two, it's an incurable disease, so we do need treatments. Yes, the landscape is richer now, but none of them are curative. BTK cannot bring people to molecular remissions. I've done this trial, it should be coming out soon in print, but BTK inhibitor by itself does not deliver MRD negative state. The opportunity for lenalidomide to bypass various known pathways and still deliver a response is unique. It's absolutely unique. The opportunity to deliver a lower dose and get the same results is unique. And so it's a perfect drug to be delivered perfectly through a continuous infusion. The buy-in is already there, as I mentioned in the NCCN, that this is a treatment. Now, if you have a better delivery system, better tolerability that we can demonstrate, then the academic community and is already primed to acknowledge the validity of its efficacy as well as the utility of benefit to achieve benefit for patients. And lastly, despite all this positive data that I've shown, for whatever reason, len has not been approved or has not sought approval for FDA. So it's a fruit ripe to pick in my mind. So I'll stop here, and I think that concludes my presentation. Sydney, back to you.
Sydney?
Pedro, do we, sorry, Jamie, do you want to take from here or?
Yeah, no, I will. I was unclear. I will pick it up.
Yep.
The study that we are planning to initiate this in the mid of 21 is what's called a master protocol, and Dr. Chanan-Khan drafted this marvelous piece of work based on some considerations about the probabilities of success and the return that the FDA gives you for those probabilities of success and return for approval by looking at more than one indication, all within CLL. We're able to mitigate risk and get lots of shots on goal, which is always a good thing, and find out how we best fit into this treatment practice that Dr. Chanan-Khan has just talked about. So the first indication in the basket or in the master protocol will be a maintenance therapy with BTK induction will be taken for at least 6 months. Patients who fail to become minimal residual disease negative will be enrolled after that 6-month period to receive the chronic infusion of lenalidomide to try to convert them to a deeper response, which would be MRD negative. So that is the first arm, maintenance therapy. Again, the largest area in myeloma for the sales of Revlimid are for maintenance therapy. So it's a very good target. The second and third line combination with venetoclax, BCL2 inhibitor, Dr. Chanan-Khan spoke about those. We want to see what happens in this population when we bring those together and see if we can improve the response to the single agent venetoclax, as well as look at MRD negative and positive outcomes. And then the last traditional arm would be relapsed refractory disease, which is normally where you see drug companies come in with new therapies. The upside here is that lenalidomide is not a new therapy. We know it works. If we deliver the right blood levels, we should see activity. But this arm specifically has limited patient options and is probably eligible for breakthrough designation with the U.S. Food and Drug Administration if we can successfully show activity on PFS as a surrogate marker. Next slide. That's me. Okay. As I said before, there are 3 arms: ABC, maintenance therapy for MRD positive patients, combination with venetoclax, and then arm C, relapse refractory. All patients come into the study. There will be 6 patients in each of those 3 arms, looking at dose 1, which is in this case 100 micrograms an hour. Then we'll go up by 50%, and we'll go up then by another 50% to the higher doses if the drug is well tolerated each month. Once we have identified the safe operating or optimal biologic dose, we like to call it, we will then move into a phase 2 arm, which would be expansion up to 25 patients per arm to determine if we can see larger expanded improvements in those endpoints. I will tell you that we also put together a master protocol because it allows us to modify the protocol, add arms, take arms away without having to start a new study, which costs lots of money every time you start a study. We also can add enough patients. Should we see great success in arm C, relapse refractory, we could actually add to this current protocol and try to get enough patients to go to FDA for a phase 2 breakthrough approval. In all of these, safety and tolerability in the phase 1 part will be the primary endpoint. There are secondary objectives that we'll be looking at some of the biomarkers that Dr. Chanan-Khan spoke about, as well as looking at pharmacokinetics and efficacy.
Dr. Chanan-Khan, a question for you. How common is lenalidomide use for treating CLL in your practice? Is the lack of FDA approval of lenalidomide for CLL a hurdle for prescribing the product?
Thank you. A very good question. So fortunately, it is not a hurdle. And that fortunate piece comes from 2 large phase 3 trials and the NCCN's endorsement that it is a legitimate treatment, that it has benefit to patients. And so when I do prescribe lenalidomide, I don't have any challenging episodes with the party payers, third-party payers, and so forth. So it is being reimbursed, it has been given, and I think people are very comfortable in terms of reimbursing for that. In terms of utility, again, it depends on where I am with the patient's continuing. We completed a trial earlier on in actually early intervention. So we recently completed a study which should be published soon, where people actually, the intent was immune stimulation before symptoms developed. Can we eradicate the disease? Can we control it? And we used 2.5 milligrams of that, very low doses. just to test and see what the immune activation happens. And very good results in that. So there's opportunities that we are using. In places where I use most commonly these days is patients who are intolerant to BTK inhibitor, resistant to BTK inhibitor, or have developed, so those patients who are resistant to BTK inhibitor, and their life survival is 3 months. In 3 months, they're done, no matter what you do. And these checkpoint inhibitors did not make any difference. I used checkpoint inhibitors on clinical trials and so there was a big push that maybe the checkpoint inhibitors would be the way to go for CLL. Unfortunately, it did not pan out to be true. And so right now, there's a huge paucity of therapeutics that can salvage these patients who are double refractory, a BTK and a BCL2 refractory patient. There's nothing for that. And that shows the third category that Jamie had shown you, that we are strategically going after that population because there's nothing available. And I don't have any reservations thinking that a breakthrough designation is appropriate. It meets the criteria, there's nothing there. And I think that would be a good position for the company to have that lenalidomide developed there.
Let me just add that a significant portion of CLL patients are treated in community hospitals, approximating 70% of them. And those patients are strongly impacted by the FDA's decision to contraindicate Revlimid in CLL patients. So although academic centers that have broad knowledge and protection from their center, from a liability point of view, do use or can use Revlimid, that is not the case for community hospitals. And so its penetration is marginal today.
Mm-hmm. Wonderful, thank you both. We have time for probably one. Great to have you here. If you do have any additional questions or would like a follow-up in any way, please make sure to reach out to Dr. Jamie Oliver, or you can also contact us through our investor relations contact. Have a great rest of your day.
Thank you.
Thank you.
Thank you.
Take care.